Hello everybody, a warm welcome to my YouTube channel. My name is Jemi Naftali. I'm a pediatrician by profession. In this channel, it's all about kids welfare. This is a channel that goes by the name Pediatric World. So pediatric basically means children. So this is a channel whereby I want to create the awareness on common illnesses affecting children while growing up. So if you're new, join this family by hitting the subscribe button. Subscribe to be part of us because we want in the end to have healthy babies. We also want to improve their qualities of life. So join the family by hitting that subscribe button because this is a family and we want it to be as big as possible. Also, if you're that returning subscriber, thank you so much for always coming back to watch my content. I do not take in all these for granted. So thank you so much. In today's episode, I want us to talk about the common drugs that are used in newborn. So maybe you have an idea of which drugs we have, especially in the newborn unit, that is the nursery. It's common drugs that we use there. So these are the drugs when you come, you are likely to find, depending because you know the cases that are usually there. So number one drug that we always do, there are IV antibiotics. This IV is intravenous. The drugs that we use are through the vein. So the intravenous drugs, yeah. So normally we use a combination. We use something we call benzylpenicillin, also called Expen, plus gentamicin. Why we want to mix the two? The benzylpenicillin is to cater for the gram-positive infections. Now, the gentamicin is for the gram-negative microorganisms. So that is why we really want to combine both of them. So these are our first-line drugs, first-line antibiotics when you come to nursery or to the newborn unit. These are the commonest drugs that you usually have. So if this doesn't work, and how are you able to know that these first line drugs haven't worked? So we don't want to start with strong ones. So we have first line drugs, we have second line, and we also have third line drug. So we keep changing depending. What will make you switch from first line antibiotics to second line antibiotics? It's for the obvious reason. If the child is not improving, maybe even after giving the IV drugs, the Expen and the gentamicin, the child still maybe has fever still. Also, if the condition is deteriorating instead of the baby getting well. So the second line drug, we use something we call ceftriaxone in the place of the benzylpenicillin or the Expen. And the gram-negative ones, we want to use amikacin. This is the drug that replaces the gentamicin. So we are saying it is a combination. We are saying it is a combination of these drugs. So the first line we are saying it's Expen or benzylpenicillin and gentamicin. Second line drug, we prefer doing ceftazidime. Yeah, we call it ceftazidime, and this we use it together with the amikacin. So this is our second line drug again from the first line drug. So now maybe you can go on and even go to the third line generation, which not commonly but mostly we reach up to there. Yeah, so ceftazidime is the second line antibiotic that you want to use in newborns. I know people know ceftriaxone, yes, but you want to use the ceftazidime. It's the same class, but ceftazidime is safer for these newborns. I hope this is clear up to there. So those are some of the common antibiotics that we normally have. We also have another common drug in the newborn units that is called the phenobarbital. I know this is not new, yeah. The phenobarbital mostly is used to treat convulsions. This child that has got the tremors, if I may use the layman language. So the convulsions, we want to treat them using the phenobarbital. So this is the first line drug of using for treating the convulsions. So causes of convulsions, I know you have done about convulsions. Go back and check my video I did about convulsions. But there are many causes of convulsions. Commonly, we have babies that have something we call birth asphyxia. Yeah, birth asphyxia is there are these babies that were delivered. They did not cry immediately. So this means that there was the blood supply was cut off to the brain, so they take time and they start conversing because the brain now has been affected. So this is a drug of choice. We start with the phenobarbital. We have something we call loading dose. We also have the maintenance dose. I don't want to go too deep into that. I just want to mention the drugs and the common drugs that we use in the newborn unit. So now, if the phenobarbital does not work, again we have got a second line drug. We have second line drug, which is phenytoin. Maybe not. It's not new. So the phenytoin is now the second line drug from the phenobarbital. If the phenobarbital is used, the baby is still conversing. Remember, we do not want these conversions to continue, because the more the baby converses, the more the brain is getting affected. So we really want to be very, very careful. So if the conversions are not stopping with the phenobarbital, now we switch to the phenytoin because it's a second line drug. We also go deep to a drug called Keppra. Yeah, it is very expensive, but it is now Keppra comes in when the phenobarbital, the phenytoin, all these are not controlling these conversions. So we go to Keppra, and it is expensive. We tell the mothers to go buy, and we keep giving this baby until the conversions are over. So those are some of the drugs that we use when it comes to conversions, very common in the newborn unit. We also have something we call IV fluids, the intravenous fluids. These are drugs, yeah, and in that we have something we call the D10, 10% dextrose. If you're a follower of this channel, 10% dextrose is not new to you, yeah. So we do 10% dextrose in newborn unit. That is the type of the dextrose that you are likely to find. We have many. We have 50%, we have 5% dextrose, but the best for the newborn in the newborn unit is the 10% dextrose. So this one is used, for example, if the baby is day one, the baby is so sick on oxygen, yeah. So this baby cannot feed, and remember, we do not want this baby to go into hypo. We don't want to we want to correct the blood sugar so that they don't go hypo. So we have to put these babies on something. So we put them on IV fluids, and the one of choice in day one, we want to start this baby on D10, 10% dextrose. It is going to control the sugars, yeah, and also this baby does not go into hypo, yeah. So this is the 10% dextrose, very common. It's a drug and it's very common. We really use it daily in the newborn unit. Now, going on, well, we have something we call the ranferon. Yeah, these are syrup, the ranferon. We also have the multivitamins. So of course, if again you're not new, I have talked about the low birth weight babies. So the preterm babies, the babies that came before the 37 weeks of gestation, yeah, and also the prematures, the babies that we have very low kgs. Normally we say below 2 kgs. So these babies, we put them on drugs, yeah. We want to put them on drugs. Why? Because they did not take the time to reach the 9 months, the usual or the normal gestation. From 38 gestation to 40, this is the normal. So they did not get this advantage. So we want to maintain them after birth because they already came and they are very low, very small. So we want to maintain them on the ranferon. Ranferon basically is to add these babies, the low birth weight babies and the premature babies. They have a low tendency of getting low HB, so their blood levels go down very fast. So we want to maintain them on ranferon, yeah. We want to maintain them on ranferon. When we are in the hospital, sometimes the HB goes down even up to below even 10, and we even sometimes we are it makes us now to transfuse these babies. But when going home, we don't want to discharge these preterm babies. These are premature babies without the ranferon, yeah. So we want to put these babies on ranferon. We calculate depending with the dose. Remember in the beginning I said every drug that is given to a newborn baby, to a child, we have to calculate it per kg of this child. So another drug we are saying is the multivitamin. So we want these babies, they are likely to be attacked, very much likely to be attacked by infections, yeah. They are prone to infections, these low birth weight babies and the prematures. So we want to put them on multivitamins. This is like to give them the immune system, to boost their immune system so that they don't get attacked by these frequent infections because they came early, because they are very small. So these are babies that we want to, until when you follow them up in the clinics, they keep taking them until we are the people that decide when to stop, when this baby is stable and now they can go on without them. So the multivitamins and also the ranferon, they go hand in hand. We want to put these babies on these drugs. Other things, we also have something, a drug commonly used in the newborn unit. It's called the aminophylline. Yeah, so the aminophylline, we again want to give these babies that are small, low birth weight babies and the premature babies. They have very low kgs, so we want to help with their lungs, and we give aminophylline either rectally, that is behind, or IV through the intravenous. So we normally have the start, and again we can maintain them with the aminophylline for like a week. Yeah, so this is another drug that is commonly found in the newborn unit, the aminophylline, again for the low birth weight babies and also the prematures. We also have other drugs that we call nevirapine and the zidovudine. Yeah, I know you are not familiar with this. These are ARV drugs, the antiretroviral therapy. So this is a child that is sero-exposed, or we call them the HIV exposed babies. So they are exposed because their mothers are reactive, their mothers are positive, they are positive, they are HIV positive. So we want to prevent this baby from acquiring this infection, the HIV infection. How do we do that? It is by starting these newborns immediately with these antiretroviral drugs. We call it, we have two, we give nevirapine and also want to give zidovudine. Yeah, so these are the two drugs we want to give to prevent the baby from acquiring this HIV infection. Very common in our newborn. We cannot miss this because we really want to follow up on this baby with these two drugs. As when they go home, they come back for clinics, we do the lab tests as we take these drugs until we find that the babies are safe and now we can stop them. So nevirapine and also the zidovudine. We also have common creams. The creams that we have commonly in the newborn unit, we have creams like zupressin or miropicin cream. So this usually it's for the aseptic rash. So sometimes you find that the baby has got it's due to neonatal sepsis. Sepsis is infection. So you find a neonatal rash everywhere. So, and this azupressin or miropicin these are creams, antibiotic creams. You want to apply on them so that it may work quickly. And most probably they have got oral, and this is what we are going to. Now, another drug is flucloxacillin. So we used to have also the ampiclox, the neonatal ampiclox, but nowadays we prefer the flucloxacillin. It's not commonly used, so it has not developed resistance. So the flucloxacillin is for the aseptic rash. So the baby is all over with spots that have got pus. Yeah, this is why we are calling it septic rash. So we want to use these creams. We want to use the oral antibiotics, the flucloxacillin. Yeah, so we want to use that at home, so that for 5 days, so that to clear everything out. So these are some of the drugs that we commonly have. If you have any comment or an additional one maybe I've left behind, you can comment in the comment section. So any questions, any clarifications, ask in my comment section. Again, do not forget to share these videos to as many people as possible. I'm sure if maybe you might hear this and your baby has got one of these drugs and you're not sure the work of these drugs, or your baby was some of these drugs were used on your baby when you're in hospital and you didn't have an idea of what they do. So this is what it is. These are the common drugs used in the newborn, the common drugs you are likely to find in the newborn unit, the nursery. So thank you so much. Again, if you haven't subscribed, kindly subscribe. So because we are road to 5K subscribers, majority of the people are watching my videos but they are not subscribing. Kindly subscribe to be part of us. And when we reach 5K subscribers, I know it's very soon and it is very, very possible. Yeah, so also give this video a thumbs up, like, comment, share, do all these things so that we may work together. Thank you so much, people. Until next time, bye bye.